All right, we'll get started. Good morning, everybody. My name is Leslie Cloud. I'm a neurologist at the VCU Parkinson's and Movement Disorders Center, and I have a special interest, both clinically and on the research side, in the gastrointestinal problems that often occur in the context of all of the Parkinsonisms. I want to start with a little bit of a friendly disclaimer. So we are going to talk about a lot of things in the next few minutes that are not typically discussed openly in polite society. So if you are shy or bashful about any of these topics, I'm really sorry. But I'm not sorry because they're important things to talk about. So sorry, not sorry. Okay, we'll get started. So gastrointestinal symptoms are extremely common in all of the Parkinsonisms. The number of GI symptoms that can occur is quite high. The spectrum's quite broad, and they span the entire GI tract from the top to the bottom. And some of the more common GI symptoms that we're going to talk about today are shown here, but this is not an exhaustive list. These are just some of the more common ones. So drooling is very common, and that's already been discussed by a couple of our presenters today. Difficulty swallowing is also quite common, and that's going to be discussed in detail by a presentation later in the morning. Bloating, feeling full too soon, and nausea and vomiting can occur. These usually occur together, and they usually occur in people who have slow stomach emptying, and that's something that we're going to talk about a little bit later. Constipation is extremely common and frustrating for folks. And then difficulty with defecation, which is generally defined as excessive straining, pain, or a feeling of incomplete evacuation during bowel movements. And then last, but certainly not least, weight loss is often the byproduct of these various GI symptoms. So we're going to talk about all of these individually over the course of the next few minutes. So why should we be concerned with GI symptoms? For starters, anybody who has ever had any of these symptoms can attest to the fact that they're really annoying and they negatively impact quality of life. So at face value, they have that significance. But they also can cause a variety of other downstream consequences that can be quite dangerous. So there are a number of serious medical conditions, some of which can even be life-threatening, that are the consequence of these GI symptoms when they're not well addressed. So examples include aspiration pneumonia that can result from difficulty swallowing, which can be a life-threatening infection. People can get an intestinal obstruction or even an intestinal perforation, which is a surgical emergency and can be quite life-threatening if their constipation gets out of control. And then malnutrition is a common downstream consequence of a number of these GI issues. So these symptoms have a lot of relevance even outside of just the fact that they're miserable. And then last but not least, if they are bad enough, they can impact other aspects of the disease. So the classic example that I like to use is if your slow stomach emptying or your constipation is bad enough, you won't absorb your medications well, and that's going to lead to a suboptimal response to medications. And so in that way, these symptoms can actually impact other aspects of your disease. So it's important to address them if you have them and treat them aggressively. So we'll start with weight loss. Weight loss is very common in all of the Parkinsonisms. It tends to be modest at first, and then as the disease progresses, you can get kind of a steady ongoing weight loss, and it can become a problem in moderate to advanced Parkinsonism. So it's very common. Women tend to be a little bit more vulnerable to the severe weight loss than men for reasons that we don't fully understand, but it certainly occurs in both genders. And there are a number of factors that contribute to the weight loss, and some are maybe more important than others for some individuals. But some of the factors that we think contribute are impaired smell, which impairs your sense of taste, and if food doesn't smell or taste as good, you may just be less interested in eating. This is more well described in the context of garden variety Parkinson's disease, but it also occurs in MSA and some of the other Parkinsonisms. Trouble swallowing can occur in all of these diseases, and if you have trouble swallowing, you may eat more slowly because you're being more cautious, and we all learned as children that if you eat slowly, you fill up faster, and so that may impact how much you're able to eat and how soon you feel full during a meal. Increased energy expenditure from abnormal movements. So if you have a lot of tremor or if you have a lot of dyskinesia or any extra movements, you're burning calories all day when you don't intend to. And that really adds up, and it can be hard to then just sort of keep up with the constant caloric expenditure. Side effects of medications. So the main medication that we use to treat the movement in all of these Parkinsonisms is levodopa. The most common side effect of levodopa is nausea, followed shortly by anorexia. So sometimes the medications that we're using to help you move better are working against you in the weight loss category. And then lastly, as diseases advance and people become more immobile, you get muscle mass loss, muscle wasting from just inactivity and not using your muscles, and that can really lead to a pretty profound weight loss over time. So generally speaking, to stave this off, we keep an eye on people's weight over the course of their disease. And if we're seeing a trend that's concerning, which in my mind is anything more than about 10 or 12 pounds, at that point we start to get concerned. And I usually recommend that folks first start with a visit with their primary care doctor to make sure there's not another medical reason why you might be losing weight. Just because you have a neurological disease doesn't mean you can't get something else, and sometimes it's as simple as someone's developed a thyroid problem or someone's developing diabetes and they don't know it, and that's contributing. So first stop is always primary care to make sure there's not another explanation for the weight loss. And then second stop is a registered dietitian to really look very carefully at what your caloric needs are, what you're eating, and how we can get you to where you need to be to try to stave off ongoing weight loss. And there are a variety of things that a dietitian can help you with, even if you have trouble swallowing, to try to help you meet your caloric needs. And I'm not going to say too much because I think the next talk is going to address some of this in a little bit more detail. Okay, so we'll move on and talk about drooling. So drooling, if you are not, this guy up in the corner, drooling is not cute. It is socially embarrassing, and nobody wants to be, anybody other than this guy drooling in front of other people. So it's socially embarrassing, and it's just people hate it, for obvious reasons. It also is potentially dangerous because if you have a lot of excessive saliva in your mouth that you're not able to manage well, it can contribute to the development of what's called aspiration pneumonia. So if those oral secretions go down the wrong way, they can end up in your lungs, and our mouths are filthy. Believe it or not, our mouths are one of the dirtiest parts of our body, and so all that bacteria in your mouth can get into your lungs and cause an infection, and that can be life-threatening. So drooling is, socially embarrassing, it's annoying, and it's potentially dangerous. The interesting thing that I think Dr. Boyce mentioned earlier is that it's a little counterintuitive, but saliva production is not increased in Parkinson's disease or in any of the Parkinsonisms. That's been well studied and shown to be not true. In fact, it actually may be a little decreased. So the reason for the drooling is that you're not swallowing as efficiently or as effectively or as often as someone who doesn't have Parkinsonism. And so as a result, you get pooling of the saliva in the mouth, and if you get enough of that, you just get overflow in the form of drooling. And so the good news about drooling is that this is a symptom that we can effectively manage. There are not a lot of symptoms that we're going to talk about today that we can do quite as good of a job with as we can with drooling. So this is a sort of a bright spot. So if it's really mild and you have pretty good swallow function, sometimes you can just get away with chewing gum or having hard candy like peppermint in your mouth when you're in social situations, because that's just going to remind you to swallow more often. That's obviously not a good idea if you have any difficulty swallowing, because that could be a choking hazard, and that's not going to work if you have really severe drooling. But if it's mild, that can perhaps give you some relief in social situations. If you have more severe drooling and you need medical treatment, we have a whole arsenal of things that we can use. And most of us take a stepwise approach. We start with what we consider to be the mildest but also the safest medications, and those tend to be topical medications that you just put directly in the mouth. And they just dry up saliva. These are not very long acting, so you usually have to use them a few times a day. But they work pretty well for mild drooling, and they have virtually no side effects because you're just putting it in the mouth, you're not swallowing it, and it's not going everywhere in your body. So for some people, that's enough. If that doesn't work, then we usually step up to oral medications that you swallow. These are more effective, but they come with the risk of potentially more side effects. But they also work very well for a number of people. And then if that fails, you can always advance to botulinum toxin injections, which have been talked about by some of the other presenters today. And that involves a simple in-office procedure. It takes less than 10 minutes. We put a little bit of toxin into the salivary glands, and that can dry up secretions for up to 3 months at a time. So that's a very effective treatment for more severe drooling. So this is a symptom that we can usually manage very aggressively and effectively. So I'll talk more briefly about difficulty swallowing because this is the topic of the next talk, but difficulty swallowing is extremely common in all of these diseases. It is perhaps most common and severe early on in the course of MSA and PSP. Particularly PSP will often even present with difficulty swallowing as a very early manifestation of the disease, but it can happen in all of the Parkinsonisms. It is typically something that kind of comes on slowly and insidiously. People start to notice that they occasionally cough or choke when they're eating or drinking, and it can be mild and intermittent at first and then become more persistent. It's important that even if it's mild or intermittent, that you mention it to your doctor as soon as you're noticing that it's occurring on a regular basis, because it really needs to be evaluated formally by a speech and swallowing pathologist, and then you need appropriate treatment because this can be very dangerous for the reasons that we talked about earlier. If you're swallowing and things are going down the wrong way and getting into your lungs, it's a setup for aspiration pneumonia, and that can be very dangerous. What's interesting about this is that there are some people who actually don't notice any difficulty swallowing, so they're not aware, and their spouse and their family members aren't aware because they're not coughing and they're not choking, and yet they can still be silently aspirating. So if you take, most of the studies have been done in Parkinson's disease, but if you take a group of patients with Parkinson's disease, even if they have no complaints of swallowing, and you do objective tests that measure their swallowing, you find that about 70% of them have some abnormalities in their swallowing, even if they have no complaints. So this can be a silent process, and so you just have to be really vigilant. If there's any signs at all, mention it to your doctor and get the testing and deal with it appropriately. So what do we do about it? Sometimes just optimizing medications for motor symptoms can make a big difference. That's more likely to be true in garden variety Parkinson's disease, where the medications tend to have a more robust effect. But it could potentially be true in these other diseases as well. Anybody who is levodopa responsive and who gets a benefit out of levodopa may see an improvement in their swallowing if the doses are optimized. And then swallow training and therapy by a speech and swallowing therapist is an important part of that. And for severe cases, feeding tube placement is always an option, and I'm just going to stop there because, again, that's the topic of the next talk. So we'll move on and talk about nausea. So nausea is probably the second most common problem that I talk to patients about in clinic. The first one is always constipation, and the second one is nausea. So nausea is a side effect of every single medication, with only one or two exceptions, that we use to treat the motor aspects of Parkinsonism. So sometimes this is inflicted by us as we're trying to treat your tremor or your stiffness or your slowness, as a side effect of the treatment of those motor symptoms. It also occurs in patients who are on no medications if they happen to have slow stomach emptying. So patients with MSA particularly, as well as idiopathic Parkinson's disease, are often diagnosed with a condition called gastroparesis, or slow stomach emptying. Basically, when they eat food or take medication, things sit in their stomach much longer than they should before they move on and pass through the stomach. And when that happens, the result is that you feel nauseated, you may feel bloated, you may feel full too soon during meals, and in severe cases, you may actually vomit. But that's fortunately not very common in MSA or PD. It's usually more the nausea and the milder symptoms. So what do we do about it? If it's a medication side effect, it's easy to deal with. We adjust the medications, and we have a variety of tricks that we have up our sleeve that we can use to help if it's a medication side effect. If it's from slow stomach emptying, changes in your diet can make a huge difference. So there is a diet called the gastroparesis diet. And it is a way of eating more than it is, a specific diet in terms of what you should eat. But it can go a long way toward minimizing the side effects. So this is a diet that involves eating small, frequent meals. So I tell people don't eat 3 big meals a day, eat 6 small ones. Basically shoot for every 2 to 3 hours, eat something, and that can really help. You want to avoid eating too much high-fat, high-fiber food in one sitting. Obviously, you still have to eat fat and fiber, but you want to spread it out throughout the day instead of sitting down and eating the whole head of lettuce in one sitting. Taking lots of fluids during meals can help move things along, and then making sure that you remain upright for at least 2 hours after every meal rather than eating and immediately going to bed, just to allow gravity to help move things through the stomach. So these simple tweaks in the way that you eat can make a big difference. Unfortunately, we don't have a lot of drugs to treat slow stomach emptying in the United States, anywhere really, but particularly in the United States. So there's only one FDA-approved drug for slow stomach emptying. It's called metoclopramide, and it is absolutely contraindicated in folks with Parkinsonism because the way that it works is it antagonizes or kind of works against dopamine receptors in the gut, and that's how it improves your stomach emptying time. But it also crosses into the brain and antagonizes the dopamine receptors in the brain. So it leads to a dramatic worsening in your movement, and it can be very, very bad. So it is contraindicated, and some gastroenterologists know this, most of the good ones do, not all of them do. And so it's important that you remain aware that this is a medication you should always avoid. And it's on that list of medications in the packet from the Parkinson's Foundation that's been talked about so much today. It's on the no-no list for good reason. So there are some other medications. They're not FDA approved for this indication, and one of them's not even available in the United States. You have to order it from a Canadian pharmacy with a prescription from a US doctor. But there are some other medications that are out there that might help. Generally, you're going to need either a really savvy gastroenterologist or a very savvy neurologist to end up on one of these drugs. So this is a field where we really need much better options. We need more research. We need better treatment options. But there are things you can do. Constipation. So this is what I spend most of my time talking to people about because it is probably far and away the most common GI symptom, across all the Parkinsonisms. And it's very frustrating for people who suffer from it chronically. So like most things, we try to start with a non-medication approach if we can. So the first thing we do is we really look at people's lifestyle factors. How much liquid are they drinking? Are they drinking enough for their gender? So for men, that's 3 liters a day. For women, that's 2 liters a day. That's a lot. And I think most of us probably don't drink as much as we should. It has to be non-caffeinated, non-alcoholic liquids. So your tea and your coffee don't count toward that 2 or 3 liters. We're talking about water, we're talking about juice, we're talking about decaffeinated tea and soda and coffee. So drinking more water can help, eating more fiber can help. The recommended daily allowance for fiber is based on your age and your gender, so it's different for everybody, but knowing what those numbers are and trying to make sure you're getting enough fiber for your age and gender is helpful. Increasing activity levels, gravity is an amazing thing. Just being up and at 'em and physically active will help move things along in your GI tract and can help with constipation. And then having your doctor really scrutinize your medication list to make sure that your medication that you take for high blood pressure or your medication that you take for, depression isn't working against you in the constipation department, because constipation is a common side effect of a lot of different medications, and sometimes it's as simple as just getting rid of the other offending medications. So we always start here, and sometimes that's enough. Sometimes it's not. Sometimes you need laxatives. So there are so many, dozens of laxatives that are available over the counter without a prescription. There are dozens that are available by prescription only, and many of them are very effective. So there are so many options. There are really no studies to guide us in telling us which ones are best in most of the Parkinsonisms. The only disease that's been well studied is Parkinson's disease, idiopathic Parkinson's disease. There's a few studies in that population that tell us that certain laxatives are safe and effective. And so I generally start with those just because they're the only ones that have been studied. And so typically for mild constipation, I start with psyllium, which is available over the counter without a prescription under the brand name Metamucil. It is a powder that is kind of coarse, and you dissolve it. It doesn't dissolve very well, but you put it in a glass of water and you drink it. That also forces you to drink more water, so it sort of helps in that way too. It is essentially just fiber. It is helping you get more fiber into your system and more water. I do recommend that people buy the powder. They now make Metamucil cookies, and they make pills, and they make gummies, and they don't work as well. So I think you're better off just sucking it up and taking the powder, which is not always as palatable as the other options, but I think it works better. They have gotten better in the last few years, and they now make a berry flavor that's a little better than the traditional one that just tastes like cardboard. So you may try the berry flavor if you just can't stomach the other one. And the other thing you can do is you don't have to dissolve it in water. You can put it in orange juice or something else to make it a little bit more palatable. And then you can combine that with a stool softener if you need it to make the stools a little softer, to make it easier to go. The one that's been studied and that I typically recommend is Docusate Sodium, also available over the counter without a prescription under the brand name Colace. Colace is very expensive, but every drugstore has a generic brand that will be a fraction of the cost of the brand name, and it works just as well. The same is actually true for the Metamucil. You can buy the generic store brand, and it works just as well. So if that doesn't work, or if someone has more severe constipation and I just don't think that that's going to cut it, then I typically recommend polyethylene glycol. This is also available over the counter without a prescription under the brand name Miralax. It's also a powder that you dissolve in water, but this one doesn't have the coarse texture, and it doesn't have the potentially offensive taste. Not a lot of people love cardboard as Metamucil, so this one's kind of flavorless, and so people tend to get this down a little bit easier. And it's very effective, and it's safe for long-term use, provided that you have normal kidneys and a reasonably healthy heart. You can use this potentially forever, and it's fine. If that doesn't work, there are a variety of other choices, both over-the-counter and prescription. Typically, my approach is I go with one in a different class that works by a different mechanism. If Miralax didn't work, I jump to something in a different class and just keep going until I find one that works. Sometimes people end up on combinations of laxatives. There is one category of laxatives called stimulant laxatives that we usually try to avoid if we can. We cannot always, but we try to avoid them if we can, because they can be habit forming, and you can over time need higher and higher doses to get the same effect. And so we try to avoid those if we can, but sometimes when we're desperate, we do have to use them sparingly. Some of these are available over the counter as well, so I always tell people it's important to tell your doctors what you're buying and what you're taking, and ask them for their input on whether that's really the best choice, so that you're not taking a stimulant laxative long term if there's maybe a better choice for you out there. So constipation can generally be managed very effectively. You just need somebody who's willing to sit down and really talk it through with you and help you figure out what the best choice is for you. All right, defecatory dysfunction. So this is generally, like I said earlier, defined as a feeling of excessive straining, pain, or a feeling of incomplete evacuation during defecation. So as it turns out, defecation is a very complex process. There's a whole lot of muscles down there that have to relax at the same time that a whole lot of muscles have to contract. And it's actually a pretty sophisticated, coordinated mechanism that involves a lot of different muscle groups. And unfortunately, just like the muscles in the rest of your body can be affected by the Parkinsonism, these muscles can be affected too. And there are some people that even develop a type of focal dystonia affecting those muscles, where basically the muscles that need to relax for you to successfully evacuate your stool contract when they're supposed to relax. And so you're pushing against a closed door. And it's very frustrating. And that's, sort of the worst case scenario in terms of this problem. When you give someone with defecatory dysfunction a regular laxative or stool softener, it does not help, again, because they're pushing against a closed door. And if anything, it may make the problem worse, because then you're just going to start to have potentially incontinence and still ineffective voluntary defecation. So It's a problem. There are not a lot of effective treatments for this. There's been a few small studies that have shown success with a medication called apomorphine. It's an injectable dopamine agonist that is approved by the FDA as a rescue agent for people with Parkinson's disease who have sudden unexpected offs. It works very quickly. And so what we do with defecatory dysfunction when it's severe is give folks apomorphine, and as soon as they feel that first sensation, that first call to stool, they inject themselves with apomorphine, and then that may facilitate an easier bowel movement. As you can imagine, that's not a particularly popular option. But if you're spending 4 hours a day in the bathroom trying to poop, which some people do, that may be, a potential solution to give you some relief. Botulinum toxin injections into the right muscles to help them relax can be helpful. As you can imagine, this is an even less popular intervention because it involves an ultrasound probe and a needle where the sun doesn't shine and in an area that is very sensitive. But it works for some people. And if you're really desperate, that's potentially an option. The biggest barrier as far as that's concerned is finding a provider that has the expertise to find those muscles and inject them successfully. But they are out there. And then pelvic floor PT, which is also on the agenda for today, so I won't say too much. But that can be helpful, and they can also employ some biofeedback techniques that can be useful. So there are a few things that we can do, but we need better treatment options and we need more research. So I wanted to include a quick slide to just talk about how the medications that we commonly use to treat the movement disorders that occur in these diseases can influence the GI symptoms, because they can influence them in both directions. So nausea and vomiting, as I said before, are common side effects of almost all our medications. Levodopa and the other medications that we use to treat the motor symptoms, often, really all the ones that work on the dopamine system, further slow down stomach emptying time and upper GI motility. And so you may have slow stomach emptying from your MSA or your PD, and then we give you a medication to help you move better, but then that makes the stomach emptying even slower and causes more nausea. And then conversely, levodopa and the other motor medications can actually improve all of the GI symptoms that are related to the action of muscles under voluntary control. So things like swallowing, the muscles in the mouth that are under voluntary control can improve with medication adjustments, and thereby drooling can improve with medication adjustments. And then the defecatory dysfunction is sometimes responsive to optimizing medications. So it's complicated, and that's why you really have to kind of talk this through with your neurologist, and they really need to look very carefully at your medications to help figure out what's going on and what to do about it. That was all I had planned for today, so I will stop there, but I'm happy to take questions a little bit later during the Q&A.